I'll start with my apologies to the psych students. This is going to be pretty simple compared to what they'll need and want to know, but this is the basics for a generalist practice. So here we go, part one. So mental health and primary care. Lots of different things that we're going to have to prescribe for. Anxiety is probably going to be one of the most common. Depression probably almost equally as common. Bipolar much less common, although we will sometimes manage it ourselves. The psych folks will be managing this on a regular basis, and those of us in primary care have to understand what they're doing because obviously the medicines are going to have implications for other issues and other medications. ADD or ADHD, very common. Primary care is sort of the folks that really do manage this predominantly, and so it is something that you're definitely going to be doing on a regular basis. Major mental illness, you're not going to be managing these meds so much if you're primary care. If you're psych, this will be, a lot of what you do. But all of these meds can have implications. Some have higher risk of diabetes. There's a lot of different things that intersect the two specialties. So anxiety, basically it's feeling afraid, having a fast heart rate, choking feeling, nausea, dizziness, tingling. Obviously, the differential for this is extensive, especially if you've got a 50-year-old who is having these symptoms. You're worried that they're having some sort of pulmonary embolus or some sort of cardiovascular event. Obviously, anxiety is one of the #1 symptoms that you get in people that are hypoxic. But in general, people that are anxious, there's not something specific that they're anxious about. That's usually fear. Anxiety is usually sort of a free-floating, very sudden, severe anxiety, of course, is called a panic attack, and lots of different pharmacologic approaches, some of which are abortive and some of which are preventive. So yes, there is a difference between fear and anxiety. If you're afraid of flying, that's not really an anxiety, that's actually a fear. So some of the medications may be the same though. So why does anxiety occur? There's lots of different theories. Really now we feel like there's three major models. The noradrenergic, in which noradrenaline is excessive. You get a burst of catecholamines. The benzodiazepine or GABA model, in which there's an inadequate amount of GABA. And then the serotonin model, in which there is an inadequate amount of serotonin. Serotonin is sort of that chemical that makes you feel okay, that the world is an okay place to be. Not mutually exclusive. All three theories may actually be true in different circumstances. We're going to try to address different things. Different medicines are actually going to impact different elements of physiology. So my feeling is it is a combination of all of these three, but different people have different opinions. So how do we treat anxiety? We can decrease that sympathetic nervous system, that excess catecholamines. Beta blockers can be an effective way to treat anxiety. We use those for fear very frequently. You're giving your big presentation. You're going into something which is extremely stressful. If you block the heart rate response and block the blood pressure response, often you'll have less of the emotional response as well. Another thing that you can do is you can basically stimulate those GABA receptors. GABA receptors are the receptors in your brain that basically say the world is a great place, you feel wonderful, you feel relaxed, you feel terrific. Things that stimulate these GABA receptors are benzodiazepines, but also alcohol and also barbiturates. So there's a bunch of different things out there that can give you that sensation. All of those things are potentially addictive and are very difficult to get rid of once people have had a substantial amount of them. So alcohol is a very difficult thing to get off of. Benzos are even harder. Benzodiazepines are much harder to get off of than alcohol. And even things like barbiturates, the one that we still use on a fairly regular basis is a headache medicine called Fioricet. It has just a little bit of barbiturate in it, but unfortunately a lot of people get very dependent on it. And unfortunately, when they stop taking it, they'll get rebound headaches. They get a headache, they take more Fioricet. It can be a real challenge, and it is very hard to get these people off that medicine because you've got the combination of the sensation of desire as well as the headaches. You can also try to balance out their serotonin. Usually we try to increase it. Some people, when you increase it with an SSRI, they actually get more anxious. Clearly that's not desirable, but most people, if you raise their serotonin level using an SSRI or an SNRI, they usually will actually feel better. So the noradrenergic model basically is an overactive sympathetic nervous system. Medication treatment for that, we can use something that blocks that noradrenergic element. Sometimes beta blockers would be the desirable effect. Tricyclic antidepressants will give you a little bit of a blockade of this, although they have a big anticholinergic effect as well. The benzoreceptor, again, GABA is that major inhibitory neurotransmitter, and obviously there is that cross-reactivity with alcohol, as we were talking about. Lots of problems with benzos. Benzos are great medicines if you've got somebody that's having a panic attack and they have 1 or 2 a month and you give them small amounts for short term. The problem with them is that if the body downregulates its ability to make GABA, which it usually will, if they're on benzos for any period of time, it takes a long time for that upregulation to occur. Less time with alcohol, usually a week or 2, and they'll feel better. Unfortunately for alcohol and for lots of medicines, and especially opioids, there is that post-acute withdrawal syndrome, which makes them feel kind of lousy for a period of time. And obviously for alcohol, that's an issue. For benzos, that's definitely an issue. And we're not talking really about opioids at this point, but that's definitely a major issue for opioids as well. So if you're going to stop somebody's benzos, you're going to have to do it very slowly. And lots of times we try to get them onto something that's a little longer acting, so that they don't notice that benzo spike like they would with something short acting like Xanax. So examples of benzos. Xanax, which I've mentioned in class many times, is my least favorite benzo, unless you have somebody that's having a panic attack. If you're having a panic attack, it seems to have nice quick onset. It does not hang around for a crazy long time, although it will be in the system for 10 hours or so. The problem is that as they start to come down, they lose that major anti-anxiety effect, and so they need more. And so it is very difficult if somebody's been on Xanax for any period of time to get them off. Ativan's a little bit easier. Again, still very addictive. Klonopin is a medicine that I really feel like is best used predominantly by the psych folks. It has a little bit longer onset, has a very long half-life at 30 to 40 hours. I usually let the psych folks manage this. Try not to do it unless there's somebody that comes to me that's been on it for a very long time. You can actually sometimes taper these people off a little more easily than you can some of the short-acting ones. So serotonin. If there's too little effect, the SSRIs. And obviously, if you put somebody on and they're getting worse, you take them off their SSRI. They increase serotonin. They're extremely difficult to overdose on. I think there's been one overdose death in history, a pharmacy tech that took 600 Prozac. Very hard to get your hands on 600 Prozac. Unfortunately, there are also the side effects, the nausea, the sexual dysfunction. Sexual dysfunction is predominantly delayed ejaculation for the SSRIs. It's not usually erectile dysfunction, although that can happen. The SSRIs are also good for obsessive compulsive disorder, often need a little bit higher dose. If you're using Prozac, you're often going to end up at 60 to 80 milligrams a day, period. You know, I think that it's something to keep in mind. Examples of SSRIs. Technically, Prozac is a zero-order metabolism, so it doesn't technically have a half-life, but basically it stays in your system for a very long time, 4 to 6 days. It's a great choice for adolescents because if they skip a dose, it's going to taper down very slowly. They're not going to have any withdrawal. They're going to be able to get their levels back up once they take a dose. So it is the preferred medicine in adolescents. And in fact, it's the only one that's actually approved for use in adolescents at this point. Sertraline, which is Zoloft, is a little bit more activating, wake people up a little bit more, give them a little bit more energy. Sometimes it makes anxiety worse because of that. Paxil is very activating and will wake people up. The problem is that the withdrawal from Paxil can be a real nightmare. So sertraline, I usually use sertraline in men. That 24 basically hour half-life kind of reminds them as it's coming down. Celexa has a little bit longer half-life, and a lot of people like it better. The others that are used, I didn't have escitalopram on here just because it used to be generic. I'm sorry, it used to be brand, was expensive. It is now generic. It's much cheaper. It's a nice choice, actually. Seems to have less side effects. Can still be a little bit more expensive. Right now, Zoloft and Celexa are what on the Walmart $4 list. The problem is that changes from month to month sometimes. So Prozac used to be on, not anymore. And it's, you know, $15, $20 a month at Walmart. So you got to double check these things and kind of keep up on them. As we say, paroxetine, which is Paxil, is another SSRI. Very difficult to come off. I have maybe 3 patients that are on it that have been on it forever, and I don't seem to be able to get them off. They're very happy on it. They don't want to change, but I don't start anybody new on it. There are people that do. It's I think it is on the Walmart $4 list at this point. So, you know, it is cheap, but as I say, it's very challenging to get people off. Side effects, I warn people about the sexual side effects. Sometimes I actually intentionally use SSRIs in a man that's got premature ejaculation to try to delay his ejaculation. I warn women that it is also delayed orgasm so that it is something that they're aware of. I also warn people that it may cause nausea for a week or so. Usually if they fight through it, that will go away. Some people find that the SSRIs just make them feel different. They don't concentrate as well. They just feel different. They feel outside of themselves. That's very distressing. Sometimes those people, you have to use more creativity, and you often will even end up on bipolar type meds, and it's possible that they do have a bipolar 2 kind of thing. So serotonin syndrome, I think, is a lot more common than we realize. It's almost like an anxiety syndrome. They'll feel anxious, they'll be a little bit shaky, and they just don't feel good. So I think I have a slide that reviews that as well. Yeah, here it is. So there's serotonin. They'll get confused, they'll get agitated, they may feel a little warm, they may be a little sweaty, they may have tachycardia. Again, a lot of these things are things that you see with an anxiety attack. Classically, you'll have somebody that's on an SSRI, then they put them on another medicine that has serotonin effects, something like tramadol. That's actually one of the great disadvantages of tramadol for some patients, is that they will get more serotonin syndrome type effects. Then that patient gets a migraine, and then they give them some Imitrex. And Imitrex also has a fair amount of serotonin effects. Combination of those 3 is very common to cause some serotonin syndrome. Now, most people that get serotonin syndrome are going to feel crappy for a few hours, and then it's going to go away. It is the severe cases of serotonin syndrome are pretty rare. You guys may have seen them in the ER, but I've never seen a case. So Unless you have somebody on high dose and then you put them on additional medicines, they usually won't get it. But you do need to be aware that these are the signs so that if somebody's got it, you don't just attribute it to an anxiety attack and keep increasing their medication. Other things that can be synergistic with the serotonin is dextromethorphan, which of course is in cough medicine. Robitussin DM, that's dextromethorphan. That's a medicine that really is more of a medicine than we really think it is. It's technically in the opioid family. It actually does have some serotonin effects as well. There's actually some evidence that if you have somebody that has a head injury and you give it immediately after the head injury, that it is somewhat protective. St. John's wort also has some serotonin type impact, and that's why it does seem to work pretty well as antidepressant. You know, patients think, oh, it's natural, it's not going to cause side effects. Well, unfortunately, it may actually lead to serotonin syndrome. So the SNRIs, so these are selective norepinephrine serotonin reuptake inhibitors. And so it basically keeps both the norepinephrine and the serotonin at a somewhat higher level. Because of this, they are more likely to be on the stimulating side, not usually great medicines for anxiety, pretty good medicines if you've got somebody that has a more sedate depression. They need a little bit of activation. Effexor is another medicine that can be extremely hard to come off. These people, you need to take them off very slowly if you're going to take them off. They get these weird shaking, they get anxiety, they get these shooting feelings up the back of their neck. It can be very unpleasant. Duloxetine Cymbalta is also an SNRI, but it's pretty chemically different from venlafaxine. So if you look at the side effect profile, they're not that similar. And it's worth looking at one of those charts that has the various side effects on them. I'll see if I can post one on Blackboard. They are also medicines that will help with pain. Cymbalta is a pretty nice medicine. It is now available in a generic form. So how about depression? Well, depression is also felt to be related to changes in neurotransmitter levels. There are people, however, that have sort of a purely, intrapsychic. It's within their thinking process. Those people are much harder to treat. Usually talk therapy is essential for those folks. They have to work these things through, figure them out. Almost always, if they're depressed for long enough, their serotonin and some other chemicals will be affected. So you'll sometimes get some benefit, but it's often a modest benefit. And so if you've got other issues, you really do need to really try to use other approaches. So in depression, the feeling is that it's either low serotonin, low norepinephrine, again, unlike anxiety, which is often higher norepinephrine, and dopamine, which is kind of a precursor to a bunch of other stuff, also may be affected. And there's a number of different medicines that seem to impact the dopamine. So how do you know somebody's got depression? Well, they can have a depressed mood, but they don't always have a depressed mood. There's lots of other signs and symptoms. So low energy, poor appetite, sleep problems, decreased libido, mood changes, even if it isn't that depressed emotion. Especially in the elderly. The elderly often present with depression without sadness. And so you definitely need to keep that in mind. So tricyclic antidepressants will increase norepinephrine. They'll block the parasympathetic, and that therefore gives you the anticholinergic side effects. This can't see, can't spit, can't pee, can't defecate kinds of side effects. It's one of the reasons that we don't use tricyclic antidepressants to speak of anymore for depression. Sometimes we do because nothing else seems to be working. But the problem with them is that the margin of safety, the difference between a therapeutic dose and a lethal dose, is not dramatically different. Unfortunately, if somebody takes 15 or 20 of these, not only does it have substantial anticholinergic side effects as far as the can't see, can't spit stuff, it also will cause cardiac dysrhythmias, including some lethal dysrhythmias. So unfortunately, it used to be the way that a lot of depressed people would commit suicide is with their depression medicines. Fortunately, with the SSRIs, that's almost impossible now. But there are people that are on these medicines for other reasons, for neuropathy reasons, or for migraine headache reasons, those kinds of things. Sleeping, you get a little sedation from these, so lots of times we'll use them for sleeping. So other anticholinergic side effects to think about: balance changes, and as noted, the heart rate will increase if you give an anticholinergic, may become irregular, and they may develop a lethal dysrhythmia. So how do we treat depression? We can use SSRIs, we can use SNRIs, or we can use Wellbutrin. Those are the three sort of mainstays of approaches that we're going to use in primary care. The Psych folks have other things in their armamentarium, but usually if these things haven't worked, that's what we're going to do, is we're going to send them to Psych. So bupropion, which is the only one we really haven't talked about, is actually a NDRI, so it's a norepinephrine dopamine reuptake inhibitor. It also seems to be a nicotinic receptor agonist, which is where it seems to have its benefit as far as smoking cessation. It helps take away the urge to smoke. It's often referred to as an atypical, not as well understood pharmacology or pharmacodynamics, but it is something that we are increasing our understanding of. We'll often use it on top of an SSRI. You've got somebody, they're on fairly max dose SSRIs. They're still sleeping a lot. They're still tired. If we need something that's more activating, that's going to wake them up a little bit more, bupropion is a good choice. There are seizures that are associated with it. I've seen this once in my life in a patient that was trying to overdose on it and took 10 of them. It's not super common, but if anybody has a tendency towards seizures, this can actually make them more likely to have seizures. So, and as noted, it can also be used for smoking cessation. So there are people that don't respond to SSRIs, don't respond to these other medicines, and we're seeing a lot of ads on TV for aripiprazole, for Abilify, for some of the major mental illness medicines, to add this to people who have depression. The data is not incredibly impressive for this. There may be some patients that do get benefit, and it's enough to get it sort of approved as an adjunct, but it's not super common that you'll get benefit. Like anything else, sometimes you'll get that placebo benefit where you tell people. We don't necessarily think that it's exactly related to the aripiprazole, though, because it is a cytochrome P450 D26 medicine, and that's actually the same thing that metabolizes the SSRIs. So what we may actually be doing with these medicines is increasing the amount of circulating SSRI without having to increase the dose. So that may be where we're getting the benefit, but this is kind of one of those stay tuned things for me. We'll see if this does make a huge difference, but right now a lot of these medicines are still on patent and they're making big money if somebody prescribes them. So, all right, that's the end of part 1. I'll meet you at part 2.